Hi, everyone. I'm glad that people were able to stay following the excitement this afternoon. It's been an exciting day. Can't say that's ever happened to me at a conference before, but always a first. And there'll probably be some great lessons learned for the conference center people to follow an actual fire incident. So, anyways, thank you everyone for coming here, and I just want to do a brief land acknowledgement here for everybody. So the city of Halifax is situated on Mi'kma'ki, the ancestral and traditional lands of the Mi'kmaq people. I'm coming from Saskatchewan, Treaty 4 territory, and it's great to be here with our presenters to hear more on on the pandemic research that they have. I'm just going to find their bios and do a quick intro for them. I believe we are starting with, I might say this too French, Lucy Richard. Lucy is a senior research associate at MAP Centre for Urban Health Solutions in Toronto. Her work focuses on healthcare utilization and health outcomes of people experiencing homelessness, with recent work focusing on new risks and impacts resulting from the COVID-19 pandemic. So she'll start us off for a 20-minute presentation, then we can do a 5 to 10 minute Q&A after.
Hi, everybody. That sounds really loud. Is that really loud? No. Good. Okay. Okay, so as was mentioned, I'm here on behalf of a very large team at MAP Centre for Urban Health Solutions, where for the past couple of years we have run what is probably the largest longitudinal cohort study about people experiencing homelessness during the pandemic, certainly in Canada, probably in most places in the world. This study was conducted in Toronto, and there was a number of goals. Not all of them I'll be able to talk about today, but we'll go through some of it. Mandatory statement, our research was very generously supported by CIHR and the Public Health Agency of Canada as part of the COVID-19 Immunity Task Force. My goal in the next, I assume I still have 20 minutes, is that fair? Yeah? Okay. In the next little while, my goal is to give you a brief overview of this study, the why and the how we did this. The bulk of the time we'll be talking about the findings so far, spanning about 6 papers so far. And probably what is most relevant for you guys is the takeaways as service providers and policymakers. This is probably it's probably obvious for everyone in this room why we would need such a study, but just to recap really quickly, why do we need a study about COVID-19, specifically about people who are experiencing homelessness? Basically because the living environments and conditions are ideal for the transmission of COVID-19. It's similar, maybe worse, in fact, than long-term care facilities, nursing homes, incarcerated environments. At the same time, populations experiencing homelessness as a group have higher rates of comorbidities that we know are associated with adverse health outcomes. If you combine those two things together, you end up with a situation where people are at excess risk, theoretically. So this study, because it is a large longitudinal study, we had a whole host of objectives that we wanted to go through. For the purposes of today's presentation, we're really just going to focus on 2, and I wish I had a pointer, but measuring rates of COVID-19 related events and really getting a sense for whether there's excess events as compared to house people. And the second would be assessing whether there are factors, and specifically modifiable factors, that impact your risk for infection and adverse outcomes. So as I said, this is a longitudinal study. We recruited a number of people and followed those same people over time. That's a complicated thing to do with this population, but thankfully the team at MAP Centre for Urban Health Solutions has been doing this for a really long time and has gotten really good at doing it. So what we did was we randomly sampled beds, rooms, and tents at 62 different shelters, physical distancing hotels, and encampments across Toronto. From that sampling, we recruited 736 people from those various sites. Each of those participants, after consenting, they answered a fairly long survey and provided 2 biological samples, saliva and blood, both of which were used to assess to measure current and past COVID-19 infection status. Because I think, as we all know now, PCR testing in the community is not sufficient. Then we followed up with these individuals every approximately 3 months for about a year. And finally, we linked this data to ICS, which, for those of you who are not familiar with it, it's a data repository for health administrative data in Ontario, which covers most of the population. That allows us to follow individuals over time to assess acute healthcare outcomes and eventually long-term chronic health outcomes. Okay, there's a lot more methodologically that I could talk about, but I will not waste the 20 minutes on that. We do have a protocol that we've published that kind of talks about that, and I'm also welcome to answer questions later. I will move on to the study findings because there's a fair amount to go through. First up, infection and reinfection, and you'll notice that I didn't start by describing the population. There's no time. Suffice it to say that the population is roughly representative of the homeless population in Toronto. There have been other presentations today already that have kind of described the population. Moving on to specifically the stuff that we're all here for, infection rates. As you can see in the little donut here, overall, what's not on the donut is that we identified 613 infection events overall in the group. Remember, we had 736 people overall. You may wonder why that doesn't cover 90% of the donut here. Well, you'll see in the darker blue, there are a lot of people for whom we've identified more than 2 infections, or at least 2 infections, I should say. So roughly overall, we have about 65% of the cohort that had at least some form of history of infection. Quite a few, about a quarter, who have at least 2 infections. This would be, in terms of history of infection, it's about comparable if you look at housed people seroprevalence studies, but what seroprevalence studies don't really get at is that 25%, that excess burden that people have with the reinfection rate. And as we know from other literature now, reinfections do increase your risk for adverse outcomes down the road. That rate translates to, depending on when you look at various incidence rates, most of our results in this presentation and our papers, we split up between pre-Omicron, which would be anything before the end of 2021, and post-Omicron, which would be anything after the end of 2021, which roughly fell about halfway through our studies. So good news for us, we can give you both. Pre-Omicron, the incidence rate for an infection event was about 35 infections for every 100 person years observed. So you can think of it as if you were to follow 100 people over a 1-year period, you would find 35 infection events. Post-Omicron, that number almost triples to 97 infection events per 100 person years observed. One thing I'll note before moving on, actually, a really important point that I didn't put on the slide for some reason is that the vast majority of the infections were not identified through PCR testing, which we also did collect as part of the survey. The vast majority were identified through those biological samples that I mentioned. In other words, the participants didn't know that they had that infection history. And by definition, neither did their service providers or anyone else. You might ask yourself, who are the people who are getting infected and reinfected again and again and again? We were also obviously interested in this. The survey was very extensive. It included sociodemographics, comorbidity history, health behaviors, work, volunteer history, that kind of thing, including also a very extensive housing history. We looked at all of these things, but what you see on the slide here kind of shakes down what ends up staying relevant after you adjust for a fair amount of confounding between variables. There's actually quite a lot that's really interesting on this slide, but because of time limitations, I'm going to have to focus on just one, and that would be this. The people in our cohort, they started out in shelters and physical distancing hotels and encampments, but they ended up moving to a large variety of different housing types, spanning all kinds of settings, including sometimes getting housed. So what we did is we categorized those housing settings into risk levels on the basis of how crowded, how congregate, and how much infection risk they might have. So for example, the reference group, low risk housing would be staying in one's own home. High-risk housing, conversely, would be those emergency shelters that are super crowded and super congregate, exactly the environments that you don't want to be in during a pandemic. And moderate housing would be the things a little bit in between. So, for example, physical distancing hotels, which, although people have their own room, they are still in a congregate setting where they would have a higher risk than being in their own space. So when you look at this variable, you do see that compared to the low-risk housing, the high-risk group do have a 74% increase in risk of an infection event. The moderate risk housing, although the risk is not erased, it is substantially lower. So the good news story, I suppose, is for all those people who did those motel, hotel kind of scenarios where they moved people out of crowded emergency shelters, it does appear to have an impact on your infection risk, although it does not erase it entirely. Okay, I will briefly talk about acute healthcare outcomes following infection, and I know that's something that's of great interest to a lot of people for good reason, but this one is a little bit more tricky to discuss just because of the nature of the data available. As I mentioned, our data was linked to a healthcare data repository. As it turns out, at least in Ontario, I'm not sure about the rest of Canada, COVID-19 coding, like the new coding that was created for COVID-19, was not very well used in hospitals, physician visits, and so on. What we ended up doing, and part of the reason is what I said earlier, the vast majority of infections were not known to the participant. There was no test confirming it. Just the antibodies in their blood told us that they were infected. So what we did instead, since we couldn't measure it directly, was we compared people with a history of infection to people without that history. And we took the 30 days following the onset of the infection and compared it to a random 30 days for people who didn't have a history of infection and looked at any healthcare, acute healthcare in that time period. And what you see here is that pre-Omicron, again, the end of 2021, people with a history of infection within their first 30 days following infection had not quite 2.5 times the rate of emergency department visits and more than 16 times the rate of hospitalization compared to people who did not have a history of infection. For those of you who are maybe skeptical about that method, we did look at the diagnostic coding that people were receiving during these visits, and within the group of people who were having an infection, sometimes they were coded with COVID-19 codes, but often you'd get things like acute, respiratory virus or pneumonia or things that you could really conceive to be actually COVID-19, but they just did not code it as such. I will note, lastly, is that post-Omicron, we don't see these significant differences, and that kind of gels with what we understood about Omicron really ramping up infectiousness, but decreasing virulence and the severity of infections. Okay, the third thing that I will talk about is maybe more the bright point here for vaccination. In our cohort is extraordinarily highly vaccinated. Only 10% of the cohort at no point during the observation period opted to be vaccinated at any level. The vast majority had a full primary series and at least one booster dose. If you look at it a little bit differently, this is just the vaccination rates over time. Basically, they just happened really, really quickly after they became available. And I only really present this slide just to compare to those really high-tech dots that I pasted on top that show the rate in the housed population of Toronto. As you can see, for doses 1 or 2, the rates in our cohort are only slightly below what the housed population had. And actually, for dose 3, we're a little bit better off. So there's a lot of reasons why this is the way it is. And by the way, this is probably the most highly vaccinated cohort of people experiencing homelessness that I've seen in the literature to date. The vast majority of the time you see vaccination rates that are substantially below the comparable housed population. So this is a really good news story. The last thing I'll note about COVID-19 vaccination, most of you will probably wonder whether vaccination has an impact on things like breakthrough infections and adverse outcomes. We don't have any data right at the moment to talk about effect on adverse outcomes because of the reasons I mentioned earlier about the data quality, but we did look briefly to see whether COVID-19 vaccination impacts your breakthrough infection risk. And well, the short answer is maybe, keeping in mind that the data is a little bit complicated here, but if you look in that table, you can see that having your first couple of doses, the primary series that they say, you don't really have a big difference in your breakthrough infection rate. But if you look at the third doses, and especially the fourth doses, you start to see reductions in the breakthrough infection rate. And again, this is accounting already for the difference in observation time based on when you had those doses. Okie doke. For you guys, what is the point of this information? What is the takeaway for you? There's really just two things that I think should be taken away from this. Number one, infection burden is breathtakingly high in this population. And keep in mind, in Toronto, like in many other places, there was a lot of enhanced infection prevention and control measures that have been put into place, aside from moving people to hotels and all that, that were supposed to mitigate risk. Clearly, it doesn't. I mean, it's very possible that it has reduced it, but it has not erased it entirely because the rates remain significantly higher than among house people, as far as we know. One key thing to keep in mind, and this was implied but not stated in the previous slide, individual level modifiable factors, things that we measured like whether or not people masked or physically distanced, these things were not associated with reductions in infection risk. Very likely that's because there's a lot of things that are outside of individual control that really does increase your risk. So conversely, the housing related factors, things like moving people to lower risk settings, going from high risk to moderate risk, that does seem to reduce your risk. The second takeaway that I would encourage you to take away from this presentation is that vaccination does appear to provide some level of protection. And that's really good news for the cohort that we studied because they were so highly vaccinated. And that really does go towards the specific outreach program that Toronto adopted, especially for the primary series, was very aggressive. I style it as aggressive, positive, I guess. There was a lot of engagement, a lot of grassroots organization, and key, in my opinion, was the use of peer champions, individuals with lived experience going to speak with people with lived experience and to address concerns before vaccination was being offered so that any questions or concerns can be addressed by people that they trust. Conversely, though, after the primary series, the boosters and the vaccinations, although they are important for continued protection, as we saw in the table that I showed earlier, the booster rates are much lower, but they are much lower across, well, everyone. And that's related to the same issues with growing misinformation. The campaigns are not as focused as they were, and frankly, most of us are experiencing some level of fatigue around the pandemic, and there's a lowered sense of urgency, possibly because variants since Omicron seem to have become less virulent over time. That's all I've got for today. I'll mention quickly that I talked about acute healthcare outcomes today. That's because that's what we've done so far, but we do have other things coming up. Probably the biggest of them is the first bullet, where we do want to look and see if we can identify long COVID in this population and measure rates of it. Just because of the sheer amount of infection, we do want to know what is the downstream impact of that. And we've got a couple of other things going on. Okay, so many thank yous to the participants of the study, to our team, which includes Stephen, by the way, who's sitting over there. You're the PI, it's your study, really. And then also the funders and the collaborators that are listed on the slide here. And thank you. Are we doing questions right now, or? Yeah. Okay. Are those stats available somewhere? Some of them are published, some of them are in progress of being published. I can share with you the ones that are out right now.
Like the ones we got, the ones that you mentioned?
Which ones?
Like, well, because I want to share it with some other people, so basically all of them.
Yeah, I'm happy to share what's already published. There are some things, for example, this updated vaccination graph, that's not planned to go anywhere, so I can easily share that with you as well. Sure.
Did you differentiate at all, like with surveys, how many people had like asymptomatic infection or were symptomatic? Like, do you know what the rough breakdown was?
No, unfortunately, because the way the survey was written, we'd asked about symptoms within the past 7 days prior to the interview, not prior to an infection. And actually, it's probably safest to go that route, actually, even looking back, because the vast majority of people didn't know that they had an infection. Now, that's probably an indication that many of them were asymptomatic. Then again, not for sure. We don't know that for certain. Mm-hmm. It doesn't reflect within the antibody levels. There's a very, very variable response in terms of how much people's antibodies are increased after an infection. And there's no reason to believe that although there is literature talking about the severity of infection being related to symptoms, we don't have an ability to correlate the two. Yeah.
Just wondering. So, in terms of when you started the study, what month was that? Was that prior to the first dose, or was it after?
Good question. The recruitment period ranged between June and September of 2021. So it was after the beginning of the vaccination stage. At that time in Ontario, there was still some restriction to who were getting vaccinated, although it was starting to loosen up. But even at the baseline period, a good chunk of people had at least one dose.
And just as a follow-up, do you know if, let's say, in connection to when you guys did the study or started the study, right? You said you had found individuals who didn't know that they had COVID, and then they found out that they had COVID. Was there any study done to show that those individuals were more likely to get the third or fourth dose of the vaccine, or that's just something that they looked at separately?
Do you mean them learning that they had COVID meant that they went to go get more doses?
Yes, exactly.
No, I'm afraid not. We did at the end of the study go back to each participant to let them know whether they had a history of infection or not, but we don't know whether that translated to any changes in behavior.
I have a question.
Sure.
You had mentioned that the cohort had a really high vaccination rate,
Mm-hmm.
and you had talked about the aggressive strategies. Was that led by any particular organization, or was it just very grassroots collaboration?
There was a whole lot of people involved, and I mentioned specifically the peer champions and specific community health organizations that went out. And the reason I say that is because my guess is that this is probably what was the most effective. So there was in Ontario, there was vaccine mandates that came into place at one point. Probably a lot of people, and particularly people who are homeless and really reliant on community services that suddenly are not available to you unless you're vaccinated. That would have been extra incentivizing to be vaccinated, but also stigmatizing and causing a lot of breakdown in trust. So probably the most positive, I hate to use the word aggressive, but it's the most effective way to bring out and get people vaccinated is to bring people that you trust and to speak to you about it rather than being told to do it by somebody that you don't trust and have never trusted for probably good reasons. Okay, thank you, everyone.
Thank you, merci. Okay, our next presenter is Markel Coulombe. Markel is a senior advisor with the Department of Health in New Brunswick, working with the Regional Medical Officer of Health in the provincial capital of Fredericton. She holds a Master's of Public Health degree from Memorial University and has over 10 years of a diverse experience working in public and population health. She is the current vice chair of the City of Fredericton's Affordable Housing Committee and has previously served on a board of directors for the Fredericton Homeless Shelter. Her specific interests include harm reduction, access to housing, sexual health and sexually transmitted and blood-borne infection, prevention, and maternal and newborn health. Markel lives in Fredericton with her husband and children.
I didn't mean it for it to be that long. That's longer than I meant to. Yeah, for sure. This is the right size of crowd. This is good. Okay, so I'm going to talk to you a little bit about what we did in Fredericton, New Brunswick, for people who are experiencing homelessness at the height of what we experienced, the height of the pandemic, and hopefully leave you with some things that are helpful. So today I wanted to walk you through how we both prepared and managed COVID outbreaks in shelter settings, but also just for people who are experiencing homelessness in Fredericton, and really focus also today on the nature of the local partnerships that supported that work and made it possible. Kind of some new things that we learned along the way and new approaches that hopefully will stick, and then some of the things that we learned that also I hope will stick. And I also really want to talk about some structural factors that increased the likelihood of successfully housing people, albeit temporarily. We did use isolation hotels in Fredericton, New Brunswick. So just talking about some of the things that we put in place to make that really successful for people. And also just to talk about the impact of those short-term interventions during an outbreak or during like case and contact management, and some important learnings and some longer-term impacts of those short-term interventions. So I'm sure everybody can appreciate if you kind of bring yourself back to, maybe you don't want to, if you don't want to, but thinking about like that first summer in 2020 and just what that felt like if you were working in this sector or working with organizations that were working with people experiencing homelessness. There was a lot of fear and uncertainty around what was going to happen. Especially like at the onset of the pandemic, people experiencing homelessness were thought to be especially vulnerable to SARS-CoV-2 infection, and also the morbidity, mortality. I think there was this assumption that people living in those circumstances were especially vulnerable to infection. And so public health organizations across Canada were really tasked with rapid establishment of response strategies for people living in these settings, and as well for people experiencing chronic street-based homelessness and for people who are sleeping outdoors and encampments as well. So this is like a really, I'm sure you can remember, a really uncertain time. There's a lot of apprehension about people who were living in these circumstances and what was going to happen. There were some predictions at the time that homeless shelters were going to experience like 100% transmission rate, and there'd be no way of preventing it once it was introduced into these settings. In New Brunswick, I'll just speak to what we did in New Brunswick, but in New Brunswick, from a provincial government standpoint and a public health standpoint, the predominant strategy was to isolate positive cases of COVID-19 at home and closely follow their contacts. So you can appreciate that is more or less impossible if you don't have a home, or if you're vulnerably housed, that becomes really difficult. And in New Brunswick, I think, at least at the onset, we had made like a societal decision that we didn't want any COVID cases. So, what does that look like for people experiencing homelessness and people living in shelters? And I guess the last thing I wanted to mention is that just aside from that initial, what are we going to do when people are sick, and what are we going to do to minimize transmission in these settings? But it was the other impacts that there was concern about, people who are already kind of living on the margins of society. What was I going to do to people, kind of push them even farther out? There was fear also around criminalizing homelessness during that time, especially when there was pretty strict public health orders that would really be impossible to adhere to if you were living in some of these circumstances, and then kind of worry about aggravating some associated impacts around substance use, worrying about overdose, worrying about risk of withdrawal. So some of those other impacts that were of concern at the time. And so I know we're all the way out on the East Coast, but I didn't want to assume everybody knew exactly where I was talking about. So this is Fredericton, New Brunswick. It's here on the map, if that's helpful. Fredericton's a capital city of New Brunswick, so don't laugh. It's one of 3 urban centers. There's some urban centers in New Brunswick. Fredericton has a population of about 100,000 people in the greater area, spread along both sides of the Wolastoq River. Fredericton's located within the traditional and unceded territory of the Wolastoqey. And so again, before I kind of get into some of the outcomes and what happened in Fredericton, I thought it was important to give a little snapshot of what the state of homelessness looked like in Fredericton at that time. So I'm using this time period because it kind of represented the peak or the bulk of COVID cases that we observed here. And so during this time, there's about 161 people on average experiencing homelessness in Fredericton. And that was just taken by monthly averages, and it didn't vary a lot. So it might have fluctuated by a few people. So it was pretty consistent during that time. You can see the vast majority of these people were experiencing chronic homelessness, which isn't ideal. And a quarter of these people would have met kind of the high acuity definition using the SPDAT standardized tool. So people living in pretty complex situations, people having a lot of just complexity to their lives. So this is sort of what was happening in Fredericton. And so this data too also came from the Homelessness Individual and Family Information System, or HIFIS, as well as the Fredericton by names list, which is a real-time list of people experiencing homelessness at any one time. I think that's all I wanted to say about this slide. And so when I'm talking about the Fredericton homeless serving sector, this is who I'm talking about. This isn't the total finite list of organizations, but these are the ones that we were really involved in to support them, to manage outbreaks when they happened, to quickly isolate people. And so Oak Center, which is operated by the John Howard Society in Fredericton, is both a low barrier shelter as well as upper level supportive housing units. So this is kind of a mix of people living in various circumstances, I guess. And it's the largest center, so it'd be approximately 60 people there at any one time between the shelter and the upper level housing units. And then the Fredericton Homeless Shelters operates St. John House, which is an emergency shelter for men. At any one time, there might be between 25 and 27 people staying there. They also operate Grace House, an emergency shelter for women, which fluctuates between maybe 8 and 10 people at any one time, as well as Brunswick Home, which is a 4-unit transitional space. And then there was also Women in Transition that was supporting women and children on a temporary housing base. And so I also really wanted to talk about, just to give some context to what I was talking about, a sort of a timeline of events. And so again, if you kind of go back to that time at the end of the summer of 2020, in Fredericton, at the direction of the Regional Medical Officer of Health, outbreak planning began for shelter settings and for people experiencing homelessness around that time. And so the initial emphasis was more on logistical planning in the event of an outbreak of COVID-19, including some going in, doing site visits, trying to really build a solid relationship foundation with our homeless serving sector, our partners there, going in and doing physical site visits, making recommendations about changes they could make within the shelter. And then also scoping in the city to determine where we could isolate people if we had to. So making a list of, literally calling hotels and motels and describing the scenario and seeing if they would go for it. Some obviously didn't, and some did. So we had a nice list of motels and hotels that met certain criteria that we were looking for. And we also created step-by-step guides for each one of our homeless serving partners about a flow chart of what to do, all the way from you have somebody that's coming in to your shelter, they're not feeling very well, what do you do, all the way to you have a confirmed case in your setting, and so now we're going to kind of roll out our outbreak management strategy. So those step-by-step guides were really helpful. And I just want to emphasize too that here was when it really became obvious, if it wasn't obvious already, that building that local team and that local multi-sector support team was really critical. And so that's when that team kind of started to gel and to meet, and we met at least once a week in the beginning, and then much more as things kind of ramped up. But you can see on the timeline that was really critical when the first doses of COVID-19 vaccine became available. And so because of that local partnership and that team we had already built, we had similarly great uptake of vaccine in Fredericton for both the first and the second doses. And so we, with our partners, we created this really great strategy both times, bringing vaccines to people, doing a lot of groundwork in the beginning to build some trust, to answer questions, go in and give presentations, meet with people, bring vaccine to the shelters and like to some of our community health center settings, so people weren't having to go anywhere. It was pretty successful, and it became really important because you can kind of see we had a solid vaccine uptake for the primary series, at the very least, before the first confirmed case of COVID kind of popped up in November of 2021. Yeah, and so then by the time the first case of COVID-19 was confirmed in a shelter, we had this fairly well-formed plan that we hadn't had to use yet, but we had this really cohesive team. They were sort of ready to operationalize what we had put in place. And then by December, we were really into it. So cases kind of started to ramp up, and that's when we were really quickly moving positive cases out of the shelter and into the temporary isolation hotel model. And so I could spend probably the entire presentation just talking about this, because I think this is probably one of the biggest lessons learned for us anyway, and arguably for lots of other places. Just the team that was required to make this possible and arguably make it successful and protect people. And this started months and months and months before the first case of COVID was confirmed in a shelter setting. And so I wish I had time to go through each one of these little bubbles, because I mean, underneath each one of these bubbles are just people. They're individual people, they're groups of people who, just stepped up for so long and worked so hard. And there's no rhyme or reason why our office, the regional MOH office, is a bigger bubble. It's only because there was a lot of words, and I wanted to make them caps. So there's no emphasis on importance there at all. But just also wanted to highlight the flow of information that was constantly coming in to our office and then kind of getting spread out to all of these partners. And so, I wish I had more time to go through this, and I'm happy to answer questions about particulars around this team. But this is what made this possible, to isolate people in hotels for the duration of their infection, or sometimes that was up to 14 days in New Brunswick, mandatory isolation. So that's what that looked like. And so just quickly looking at some of the outcomes here for that time period between November of 2021 and the end of March 2022. You can kind of see what the breakdown was. It's not surprising that the majority of cases here were people who identified as men. They would represent, the larger proportion of people experiencing homelessness in Fredericton. What I thought was interesting was the average age here. So that's the same as the average age for the population of New Brunswick, which, if you're familiar with New Brunswick, tends to have an older average population than the rest of Canada. And I think, again, it just reflects the nature of who is experiencing homelessness in Fredericton. If you kind of remember the first slide, a lot of people, 3/4 of people were experiencing chronic homelessness, and the average age was surprising to me. And as cases would come in and seeing the ages of people, that was something that I still think about. And again, not surprising that the majority of cases came from Oak Centre. They were the largest facility that we worked with. And so again, just looking at some of the outcomes here. So again, this is between November 2021 and the end of March 2022. And so these, so I have a little asterisk there because these are just confirmed cases. So these are cases that we confirmed either with preliminary chain reaction, PCR testing at the beginning, and then later when point of care testing became sort of like the accepted way of confirming cases through point of care testing. So this wouldn't, so this is just the total number of cases that were confirmed to us. And I just wanted to add too, there were more confirmed cases that we were aware of, but this was based on like a chart review, a retroactive chart review. And so some of the charts were really incomplete, missing information, and so they were just excluded. I didn't include them. But I also will say that I feel like this number is probably pretty accurate because of pretty intense testing regimes that a lot of these shelters had in place. So either everybody getting tested at the door when point of care testing came in, anybody who was symptomatic, obviously, and then a lot of our shelter spaces were just routinely testing people, 2 or 3 times a week, their entire population. So we picked up we feel pretty confident that the confirmed cases are a pretty good reflection of the actual number of cases within those settings. And then I think it's also important to look at how many people we house temporarily in isolation hotels. So again, if you go back to the first slide, or the first or second slide, looking at how many people were experiencing chronic homelessness and how many of those would have been defined as, like high acuity, so a lot of complexity. And, over half of the people who had COVID during that period were isolated on their own in one-bedroom apartments, essentially at a motel. And through all of that time period, through all of those people, there was one damage and security complaint. There was just one that we were aware of. And looking at outcomes of people, a very small percentage of people ended up in hospital. And I know it's not always really valuable to differentiate, but we didn't differentiate between whether people were admitted to hospital because of COVID-related symptoms, or if they tested positive for COVID-19 after being admitted to hospital, which was a hospital protocol in lots of places. So again, it's not always worthwhile to differentiate, but I didn't differentiate between that. And then looking at the number of people recovered, just wanted to clarify too, for that was the period of time that we were following people, so that 14-day period. So I don't know, things after that, or if people, had reinfections, or we didn't follow that. And so this kind of represents about a 33% overall prevalence rate, which is pretty consistent with some other literature that cites typically, around 35% prevalence rate for people experiencing homelessness. Yeah. And so here's, so for us, in Fredericton, we fared quite well despite some predictions, and people experiencing homelessness did not experience higher rates of morbidity, and there was no documented mortality that we were aware of during that period of time compared to the general population. And in some cases, the intervention associated, I hate saying having COVID was a net positive because it may not have been, but for the short term, I can think of some examples of people who had been sleeping outside, and our outreach team had gone and they were feeling unwell, and they had them tested and they were positive, and so they were brought to the isolation motel, and all this wraparound care, kind of came in. And I can think of one person who was at risk of, had previously lost a couple of digits, and due to frostbite was at risk of maybe losing some more, but because of our partners and our primary health care team that was there and our outreach team, we're able to prevent that. I can think of somebody else who was just entering homelessness, had tested positive at the door, and in the span of time that they were there at the isolation motel, were able to be diverted away from the shelter. So a housing opportunity was found for that person. So, I mean, there's lots of examples of that. And again, I don't want to say having COVID-19 was a net positive, but I think when you're living in that circumstance and you have a lot of other priorities, if that was kind of what got you in and got you in touch with care providers or people, and that relationship continued, hopefully it did have some sort of positive impact. And so I also wanted to talk about the use of temporary isolation hotels. When used with this multi-sectoral collaboration, this local partnership was very successful in housing people who needed to isolate away from others. So it helped reduce transmission within shelter settings. And although this is done on a short-term basis, this model obviously is not dissimilar to a really high-quality supportive housing model with that on-site wraparound supports that we'd love to have and love to see. So yeah, I think that's all I had for today. If anybody had any questions.
Just to follow up on your last comment, has the New Brunswick government actually put anything forward around initiating moves towards permanent supportive housing, or have you been able to use that?
Yeah, certainly. I think there was a lot of lessons learned, because this model was also done in other cities in New Brunswick as well, and so I think there was a lot of things learned about that, and especially that aspect of low barrier. And I think that was, and it sounds really simple, but for a lot of people that was a big aha, oh, if we keep our eye on the goal, which was to isolate people house people, that's what happened. And we didn't really care how that happened. So people got emergency safe supply, people got joints delivered to them. They, some people had managed alcohol happen during that time. So I think it really did open people's eyes to what it took to successfully keep people in wraparound, low barrier supportive housing. So yes, I think the provincial government did take note of that and is working towards replicating that model on a longer term basis.
I can just talk loudly.
Sure, yeah.
What was the uptake of vaccine in the population?
I know, and because this is my own fault, because I, in the middle of this, had another baby and have been out of work, and I'm just coming back to work. And so I was reviewing charts, and I wanted to include the vaccine rate. It was very high. It was probably comparable to what you reported, but I don't have the specific number because I just didn't have time to go through it. But it was between 85 and 90% for the first dose, I know of that. And the second dose was similar, and we did have some drop off with the booster doses, but it would have been comparable, I think. Yeah, not as high as the record-breaking rate in Toronto, but it was pretty high.
Can I ask another question?
Yeah.
Okay.
Yeah.
For the 20 people, you listed 53 infections and 33 people who were isolated. So there's either 20 infections or 20 people or something in between that didn't get isolated. So what happened to those 20 people or infection events?
And I know it's tricky with this data because the numbers are so small, and I was careful, some of it could be really identifying, but so if you remember, so Oak Center is one of the settings that we worked in, and the upper levels were individual one-bedroom apartments. So when people had access to their own single-room dwelling, they would isolate on site. And then there was occasionally when we had larger outbreaks in shelters and we had already moved a number of those initial cases off-site, we ended up just managing sort of the situation at the shelter, which was very difficult because we were asking people to isolate as a cohort for 14 days, which was really tricky. But that kind of explains the discrepancy between, not everybody went to the hotel. But.
Got it, okay,
Yeah.
thank you.
I wonder if there was any thought or discussion around the ethics of the isolation in hotels, especially for unhoused individuals, for that 14-day period, and then they were essentially.
Yeah, that was really, that's a good question, thank you. That was something that was really difficult because, and again, for people who were living in encampments and people who were sleeping outside, the isolation hotel was presented to them as an option because we really didn't want to, aside from public health orders at the time, which were made into law temporarily, we didn't want people to feel, so we kind of used this approach that if you were in shelter, it would be well, you can't stay here, but you don't have to go to the isolation hotel, it's there for you. And so, that was really hard. Some people who were living outside didn't want to stay in the hotel, and that was their choice. But it was tricky because some people obviously did. It was January, it was really cold. I still struggle with that because it was really difficult telling people to leave after that 14-day period. Yeah, good question. I don't have a good answer.
Quick question.
Yeah.
So my sergeant, reaching home.
Oh, hi.
I usually get asked questions for examples. I always like to ask the question back to communities to get more examples for myself. In terms of the partnerships that were developed, were there new partnerships? And the second question is, how is there anything being done at the current time to maintain those new partnerships, and what are those activities looking like at the time?
Yeah, and some things probably were unsustainable. The provincial government at the time contracted the Red Cross to provide meals for people who were staying in isolation hotels. So, so that obviously kept people pretty comfortable in the hotel. They were getting 3 meals delivered to them a day. So I'm not sure that could go on for the long term. But I think one thing that comes to mind that I think does persist actually is more of an emphasis in Fredericton on the concept, because it's new for some people, and I think about our public health staff. The concept of offering safe supply was something that I don't think people were really familiar with before and didn't really understand, but were really willing to do it in like an emergency situation. So I'm thinking about people who are addicted to opioids and aren't currently in any kind of, aren't connected to any kind of care provider. And so when people were going into isolation hotels, we really worked closely with outreach workers who were really familiar with people and were able to get like honest information about what they would. It was always pitched as like, what do you need to be successful here for 2 weeks? Like, what do we need to bring you? And so sometimes that was replacement medication. And so we had a really good connection with two addiction medicine physicians in Fredericton who operate differently, but kind of towards the same end. So they were very available to like start people in a really low barrier way, either on just like straight up replacement medication or start or continue an opioid agonist therapy program. And so a lot of people have continued who maybe started during that time period and are still in that program. And some of them are not, but I think it was maybe that like willingness to provide replacement medication and offer safe supply that I think really was like a catalyst for people's willingness to, because it was so effective at like the goal that we had at that time. So I think people really saw its usefulness. So that was one partnership certainly that I think was newer and has persisted. Yeah. Thank you.
All right, our last two presenters. I did not have a bio for Dr. Stephen Wang, so I Googled it. Sorry. And so this is the director at MAP. I don't know if that's still current. Okay. And is one of the world's most renowned researchers on homelessness and housing and has led a number of groundbreaking research within this area. He also has with him Parvin Merchant. And Parvin is a director at HLMS. She brings international work experience and perspectives on systemic issues related to poverty and healthcare. She has worked extensively in housing homeless individuals and is calling for a holistic change to reduce homelessness and social isolation.
I know it's the last presentation, but I'll take 1 minute to open up. It's a long day. Okay. And with a good break in between that we got to go out and enjoy the cold weather as well. Okay, so today we're going to talk about mortality among residents within supportive housing. This is something that I really wanted to work on. So we were able to, HouseLink and Mainstay were able to partner with MAP, and Dr. Stephen really agreed. That was an amazing piece to work on this. We also had two students, Kathleen Ramsey and Mohammed Sahid from UFT. They are medical students, so they really helped us look at the research, and we're working on the paper. So just to give a background that why did we look into working on this one. When I started the position as a director within HouseLink and Mainstay, I saw that the number of individuals passing away within supportive housing was very high. I connected with other agencies and they were seeing the same thing. We're trying to understand what is the reason of it, what was it? We were really sure that it was not COVID for sure. It was because we were housing people that were formerly homeless, who comes with complex physical health issues. So we wanted to take a deeper dive and try to understand those pieces. What is it? And we wanted to study further down and have something more concrete that can be an evidence base. As knowledge is power, we really wanted a research that can work on, talk about it, and we can use those as a tool to advocate around people that have been formerly homeless and reduce the mortality, whatever that is happening around them, and make the changes. We also wanted to advocate for policy change. So then this research is going to help us that as well. We're also going to be able to look at other housing providers and what other efforts can be put in place to reduce the mortality. I'm going to give it to Dr. Stephen Wang to talk about what it is, where did we start with, and all of the different populations and the method we used.
Hi, thanks. So just to reiterate, we know that people experiencing homelessness have much higher mortality rates than people in the general population, but we don't actually know for sure if when they move into housing, if that mortality risk goes down or not. And actually the research evidence on this is conflicting. There's actually quite a bit of evidence, I think, that favors that it does not go down simply because the person gets housed. So what we did was we looked at people who lived in a HouseLink and Mainstay 145-unit supportive housing program in Toronto. We looked at everyone who lived in the building from January 2018 to December 2022. So that's a 5-year period, which obviously is 2 years before the pandemic started, and then the first 3 years of the pandemic. So just to point out that there are two groups of people that lived in this building during that time. So group one is the people who moved in before we started to observe for mortality. So essentially, these were people that had been living in the building for various periods of time, from just a few days to many years. And then group two are the people who actually moved into supportive housing after January 2018. So we actually observed them for the entire time that they were living in supportive housing. And I should mention that essentially all of these individuals were homeless prior to moving into this supportive housing building, which is essentially dedicated for housing people who were previously homeless. So we used the HouseLink and Mainstay tenant database to identify everyone who left the building and or moved out or died. So I know it's hard to read the slides, so I'm just going to summarize them to you verbally. So what we did is we identified 222 people that lived in the building during this 5-year period. Their average age was 49 years, and about 1/4 of them were actually quite young, under the age of 40. About 78% male, 22% female, and 144 of them were in the building at the beginning of the 5-year period, and 78 of them, or 1/3 of them, moved in during the observation period due to vacancies occurring in the building. So over this 5-year period, we observed 34 deaths in the building. The average age of death was 54 years. About 15% of the people who died were less than the age of 40 or under. About 76% were male, and about 70% were people who had moved in prior to the start of the 5-year period, and 29% were people who had moved in during the 5-year observation period. So now I'm going to tell you a little bit about the people who died. So this is the 34 people who died. So this is what's called a box and violin plot. So essentially, this shows the age of death. This is 60, 40, 20. So that's the age. Each black dot represents one person. So this line represents the median age. So 50% of people died at an age roughly younger than 59, and 50% died at an age older than 59. And actually, interestingly, 25% of the deaths occurred in people who were age 50 or younger. So it was a very relatively young group of people who were dying. Although you can obviously see that there was a broad range. It was anywhere between 30 and about 78 years of age. Now, when you look at the year that people died, because we have a 5-year time period, what you can see is that the number of deaths was much higher it was higher in 2020 and in 2021. So we did do a statistical test looking at this, and interestingly, it's not statistically significant, but it certainly is a suggestive pattern, and it does fit with, I think, observations in the world of supportive housing that during the pandemic there were more deaths than before. So the next slide actually shows two of the most striking findings. So on the left, it's the place of death. and the blue represents people who died in their housing unit. So 71% of the deaths were people who died in their housing unit, which means that they were found deceased in their unit after having been there for a period of days and sometimes weeks. 20% died in hospital and 9% died outdoors or in a public place. But this is really striking given that nowadays, I'd say, at least in Toronto, it's very uncommon for people to actually die in their home and be found dead. Normally, the most common place of death is frankly is in the emergency department or the hospital. On the right is the causes of death, and what you can see is that, this is causes of death as it were known to the housing program. We didn't have access to death certificate data. So what you can see is that actually, as a result of that, almost half of the deaths, we don't really know what the cause was. But where we did know what the cause, 32% of them were drug overdoses and 18% were natural causes. So now I'm going to show you what are called survival curves. So these essentially show, you start at time 0 and it shows you 5 years of survival. If everyone survives, then the line stays at the top and doesn't go down. If everyone dies, then the line goes down and hits 0, which is the bottom of the graph. So essentially, going down is bad. So we graphed both group 1 and group 2, which is the people who are already in the building at the beginning of 2018 and the people who moved into supportive housing over the time period. And interestingly, they both declined at a similar rate. And essentially survival at 5 years was 78% for both groups. So essentially what this means is that for someone who either is living in supportive housing already or who has just moved in, there's a 22% chance that they'll be dead within 5 years, which is a pretty concerning statistic. Now, I should point out that we don't have comparison data for people who were homeless and didn't move into supportive housing or for the general population. So this simply describes what we saw in this particular supportive housing population. There. So this shows, obviously age affects your likelihood of survival, and normally we expect younger people to have better survival and older people to have worse survival. So what we did is we actually separated the group into people who were 40 or younger when they moved in or started to be observed in for death, and people who are over 40 years of age. So on the left is the graph that I just want to draw your attention to. So for people who were 40 years or younger at the time we started to observe them for death, interestingly, what we saw was that in group 2, which is the dotted line on the left, the people that were under 40 and who moved into supportive housing from 2018 onwards, the survival at 5 years was at 2.5 years was only 70%. So in other words, there was 30% mortality over 2.5 years. So this doesn't definitively prove anything, but it does suggest that there's the younger people, relatively young, right, 40 and younger, who are moving into supportive housing may be at particular risk. And this just shows you, if you just look at the people who moved into the supportive housing building from 2018 onwards, so we were observing them for the entire time period, this shows their survival. The dotted line, the lower line, is the younger people, and the solid line, which is higher, is the older people. So the lines are not significantly different when you do a statistical analysis, but just looking at it, what you can see is that the younger people had a worse survival than the older people who were moving into the building. Again, suggesting that we should be concerned not just about older people who are moving into supportive housing from homelessness, but younger people as well. So just to summarize our findings, we observed a high mortality rate among previously homeless individuals after moving into supportive housing. a strikingly high proportion, more than 70% of deaths occurred within the housing unit. At least 1/3 of the deaths were caused by overdose, probably more because we didn't know for sure what the cause of death for about half. And younger individuals who have moved from homelessness into supportive housing have a risk of death that is at least comparable to that of older individuals who make that move, and it may in fact be worse. So I'm going to pass it back to Parvin to finish up.
So within our study, it also suggests what we missed or what is there to learn further. As you heard that there were causes of death that are unknown. So we don't know much about what were the causes, so we can't do much there. There are the other pieces about formerly homeless people, about their physical and mental health needs. We all know that they have complex physical health needs, but we don't know about these particular individuals. What were their circumstances? What were the other pieces around their family? Were they isolated? Did they feel part of the community within the supportive housing? So those were the other pieces that we don't know about the population that we did the study. So the topics that comes around for discussion is that there is a real need for innovative approaches within supportive housing is required. We cannot say that housing can operate in silos. We really need to bring together harm reduction, primary care, other needs for this to be successful. We really need to work towards the needs of the homeless population in very different ways. So what are the other things that we can put into place that can help this? What can we do to combat and reduce the mortality among this population? So some initiatives that we took within our housing, I can just talk about a little bit about those pieces. We really need harm reduction support. As we saw that the number of overdose deaths have gone up, though there is a supervised injection site closer to our property where we studied this, but we found that our population is not willing to go or travel. So we're trying to support them by using buddy system within their own building, having some peer workers or individual tenants that can take the role of peer worker after hours as well. We have started to keep a lot of supplies within the building. Our security has been trained for naloxone as well. Naloxone are freely distributed within the building. Even safe supply kits, used supplies, where can they dispose of, what can be done. So those kind of pieces our staff have been able to work with them. We were able to break the relationship about we being the housing provider as a landlord. We're able to now have more conversations with the client, and now they're open to talk about their harm reduction needs, because that was a barrier. They always felt, oh, this is the landlord. He's going to evict me if I'm going to be using within my building. So we are able to break that barrier as well. And now we are able to go to our funders and ask them to fund us for a full-time harm reduction worker within the site, because that's a needed one. It's harder to maintain the partnership because right now we do have partnerships with agencies that come out, but during COVID we saw that didn't materialize. The priority of these agencies have changed. Recently, the agency that was coming around and serving this population have changed their mandate to serve individuals that are homeless rather than the ones in the housing. So we don't get those staff coming to our site and supporting us. So we really want us, housing provider, to build ourselves and provide those support within our building. So that's the main step that we have taken, and that's the big chunk of our piece of work. The other is physical health needs. We really know that our population has complex health needs. They do prematurely age as well. You see early signs of aging at the age of 35 and 40. So what are the other pieces that we can do? We've checked and knocked at many doors for the healthcare teams, centers to come out and support. We have not been successful. We're still seeking partnerships with the other agencies that can come out and provide those support, which is really tough within the city of Toronto to get that support. But we haven't lost hope. We still are working currently with McMaster University, and there is a higher chances of them coming out to try their model of care, and that may really help. And we may be able to talk about it next year about if that goes along and then how successful that was. Lastly, because we know about these complex health needs, we were able to request a fund to develop a training curriculum for our frontline workers that how to support this prematurely aging population, because we do hire people, but people are not our staff are not experienced or have studies from geriatrics, so they're not able to provide that support. So we have been successful in getting that. We're going to be doing those training curriculum in partnership with Toronto Hostels Training Center so that the training can be available for people that are not within the supportive housing as well, so shelters and other workers can partake in those training. The other piece that we are looking into, that the training would be available online, so people outside of Toronto can also benefit from those training once it's developed. The curriculum that we are going to work on would be 4 different topics, and one of them is social isolation. Because we know that within this population, we don't know their family members. It's again up to them to disclose their personal information, which they hardly disclose. So we never know sometimes whether they have family or support within their housing. So those are the pieces we really need to tackle and understand more within the social housing context as well. That's it from us, and I would like to thank you to Dr. Stephen and the students that supported us to understand and learn more about this research.
I think I can speak loud enough. Oh, okay, sorry. I'm curious, what are the components that make this supported housing?
Do you mean just this site or the entire?
Yeah, it just seems to me that what is happening here?
So within what HLMS does is provide housing for people with a low income. But this particular site, we work with City of Toronto to accept the population that have been homeless. Our main criteria is that the individuals that are being homeless for more than 5 years, that are really hard to house population, those are the ones that are housed within this building. We do only have housing support within our building. We don't have full case management as well. It's just some components of case management, but not full. So the only staff that we have is a housing support.
Hi, I was just interested in the last bullet about the harm reduction you mentioned is a need because you mentioned over 1/3 was possibly overdoses. But I feel as though the community engagement piece is also a very important piece, and I'm just curious, is there community activities, a common room or something, some structure within the building that allows people to meaningfully engage with one another?
Yes, we do have it, but it was not part of this study, so I didn't mention. We do have, because this is 100 plus unit building, we have a big common room space within the building. We do have a lot of different activities that happens within the building. From the last study that we did with the MAP, you were able to use that study and able to get funds to start a commercial kitchen within the building. So we are able to tackle the issue of food security. So we do deliver cooked meals within the building for the tenants 3 times a week. We still need money to prepare the food. We were only able to secure it for the kitchen to construct, but we are still looking for funds to continually provide 7 days or 5 days of meals. We have the common room where our staff does arts, games, coffee group, as well as a separate community kitchen program where individuals can come down and learn skills. So that is a little bit different, where the tenants come down and support and learn and prepare the meals together. They have coffee and discussion groups. We have more cultural activities depending on the tenants that really want to learn about some cultures or they want to celebrate some cultures within the building. Nothing for me? Because I heard you ask everybody.
I might have one. So I was wondering, because I saw the rate, as you mentioned, Stephen, with those that moved after the January 2018 date,
Yeah.
they were younger.
Well, no, when you're talking about this one. So these are people that we observed them from the day they moved in. And the younger, when you look at the younger people, contrary to what you would expect, they have a lower survival
rate. Yes.
It's not statistically significant, but it's concerning and suggests that future research should look to see if perhaps overdose is driving this observation.
That was actually my question. Like, was there any connection to like the cause of death that we had seen, like,
So
with regards to overdose?
we are going to do that, but the problem is because we're missing cause of death for half of the people, it's a very limited analysis. And remember, so this study was done completely using Housing and Mainstays data, which is really like it's really like a landlord, like client database. It's not a medical database. So that's why cause of death is basically, I think it's literally based on, what the paramedics and police and the hospital told them after the fact.
Because
Or what
this
they
is again-
observed.
or what the staff may have observed. Because again, as I mentioned earlier, the major challenge we have is because we are the landlords.
Right.
So we don't get the information. Even paramedics sometimes will withhold information. You don't need to know what happened there. And most of these population don't have family. So we would never hear from anybody that what had happened.
I'm also wondering now, like, in terms of the cause of death that they were mentioning, do they have suicide? Because some of the research that I've seen does show that younger age groups are more likely to report having mental health challenges. Was there anything that showed that?
So yes, it should be there. We really don't know. That's why we're really emphasizing on social isolation, because again, as a landlord, we don't know the reasons, that they don't disclose that with us. But again, being a landlord, we have seen the body, and that would really say that that would have been a suicide. But again, we cannot report it that way unless there is a certificate or something that says that it was. For this purpose also, we really didn't want it to count it again as a suicide because we really don't know. It would be just hearsay, or people would just have been just making up. Whatever we put here is self-reported by somebody around that situation, maybe paramedics or police. Those are the ones that we have included in this study. Other ones that were guessings or mentioned by the staff, we didn't include those.
Thank you.
Thanks.
Oh, I'm going to ask
question.
a really methody question, if you don't mind. I was surprised to not see a difference between the people that were there prior to 2018 to the people afterwards, because I assumed that there would be a survival bias for the people who had been there for a long time. Do you have any comments as to why that didn't happen? Like any insights, perhaps?
Yeah, so maybe I can just explain the question. So it's a really good question, because if you think about it, the people who moved in, the group 2, they are fresh to the building, and you'd think that, okay, well, that's a high-risk period. Group 1 were people who essentially had lived in the building for months or years, for the most part, and you would think they're going to have a lower mortality rate because they've had they've essentially survived to make it to January 1st, 2018. So the people that moved in and died quickly, they would never be even in the study. So going into it, I actually expected that Group 1 would have a better outcome than Group 2, but we didn't see that. So I can't actually really explain why that happened, and all I can say is that it does not appear to be like they were younger or anything,
Okay.
right?
That's
or
weird.
or
Interesting.
older. Yeah.
Okay, thank you.
I mean, I guess the bottom line is that, like, if you are operating a housing program for people who are previously homeless, you got to be concerned about everyone, not just the people who just moved in. I think that's the bottom line.
I have a question. Would you see the gap then being those wraparound supports and the access for the people that were in the housing units?
So what we understand is that people that are home or formerly homeless do have challenges. So this we have only been able to study within the supportive housing context. We don't know if they're living in families or living somewhere else. Would this be the same for them as well? So we don't know, but what we see here is we're trying to understand what we are seeing them when they are there and what are the presenting issues that we see. We do see complex health issues, and we were able to highlight it because there are so many things that are connected to it. We do see that they feel isolated. They want to be part of the community, how volunteering helps them. So what are the other pieces? Other thing we heard was harm reduction. So these are the things that we can put together to close those gaps and reduce mortality.
Thanks.